Sorry. Okay, can everyone hear me now?
Yes.
Okay,
We
welcome
can't see
everyone.
you. We can't see you.
Oh, okay, sorry. Okay. Sorry for the technical problem. It is indeed very complicated. Welcome everyone to our fifth webinar organized by the ASPA-FLEX. Thank you for joining us on a Sunday afternoon. And today our theme is on pediatric sedation. On behalf of the ASPA Education Committee, I would like to express our sincere gratitude to all our speakers today. Our speakers are not just anesthesiologists with experience in pediatric sedation, but they are also clinicians with passion and mission to promote safe and high quality sedation in children. Moreover, I have to express my sincere gratitude to our IT support team, Dr. Weber and Dr. Teddy Fabula supporting us so that this webinar can run live and happen. So go back to our program. Today we have 4 talks by 4 renowned speakers. And our first speaker is Dr. Agnes from the KKH Women's and Children's Hospital. Dr. Agnes is a senior consultant from the KK Women's and Children's Hospital. She's also the founder of the ASPA. She's actively involved in medical education and training locally and in Asia. She has organized and set up the sedation committee of the KK Children's Hospital, and her talk today is the path to safe sedation, getting all on board. I will pass the time to Dr. Agnes. Thank you.
Good morning to all. A good Sunday to all. Thank you for joining us on this Sunday. I will just be sharing with you some of my challenges that we face when we embark the path to safe sedation in children. In this tunnel is a probably 2 to 3 month old baby fast asleep, undergoing a single region MRI, just been fed, diaper changed, snuggled tightly in the pink blankets you see there, and it'll be a success. Now, fast forward, say 6 months from now, it will still work, but there's a possibility that, the baby might just wake up strong enough to struggle free of the blankets and even start crawling out. So at this age, or even older, in young children and infants, you probably need sedation even for a non-painful procedure. And yet they are the highest risk for complications and we should have a zero tolerance for any error. The depth of sedation, we need sedation, but we often don't know whether it's moderate because, you're going to rouse the child or the baby once they're asleep, right? And we need them to be moderate to deep sedation to successfully complete the procedure safely without major psychological trauma to both child or the sedation team members. And in older children, because of the underlying conditions, we also need to have to sedate them for some procedures, both painful and non-painful. Now in KK Women's and Children's Hospital, it's a public hospital, most of the frontline work is done by junior staff, sedation management also. But at least in the daytime, the specialists are around. But at night, apart from pediatric anesthesia department or children's emergencies, most specialists would have gone home, and the junior staff would have to manage everything on their own, including sedation. So with this in mind, two initiatives were started about 16 years ago, medical simulation and safe sedation. So the first meeting was in 2004, what I considered the meeting of the elders. They were the senior consultants who from the various departments that did sedation. And we had a good powwow, but it was no surprise to me that all the departments had their individual sedation policy and protocol. So we decided that we needed one ring to rule them all to ensure safe sedation. And that is a unified hospital policy and procedure on sedation. But this surely would just be useless if we can't translate into actionables. These are the elements of perhaps any sedation policy and protocol you see from any hospital. But what we need to do is to ensure that all these elements are translated into processes that those on the ground would understand and able to carry out. So that's why it was important that we form a sedation committee. They were mainly medical and nursing members, and we used the pharmacist as an expert resource as and when we needed. But sometimes people are arrowed to join committees, and some don't really want to get on board. And when they're on board, they don't really want to be there. But hopefully, all on board will be of kindred spirit in promoting safe sedation when we all know what the objectives are. And I was very lucky actually to have a very good core group who are still with me 16 years later. So it's important to have a working relationship with all the areas that does sedation, to go down to the ground and know that, what are the things they need, resources they need, what are the training needs that they do, and help them reach, Okay, so what are the challenges that we face? These are the four main challenges. The sedation form, because previous to that, each department or area had their own sedation form. So we came together, the committee members, they input all their ideas, and we were able to produce a document that contained everything on just one form. And what was important was on the main page, the first page, contraindications loomed large, so that the MO who is assessing the child or the baby for the sedation would know where they can't go, when they should not go. These are the sedation models in KKH, and the nurses are able to order the oral sedation, administer the sedation without a doctor. Fasting time, that was actually quite challenging. Being an anesthetist who's used to 6 hours from solid feeds, I had to understand, that, that a hungry child is an angry child, and that there's wide practice variation in the fasting times. So there was not very much literature about 16 years ago. The most came from Children's Emergency. I think Green, had a lot of publication on that. But listening to the ground, who had decades of experience, we decided that since no propofol is allowed, we would then allow 3 hours fasting for solids in those group of patients that had a negligible risk of aspiration. And 2020 now, this year, of which two of the authors are in our panel today, Vivian and Kira, those with negligible risk factors negligible aspiration risk. The fasting is 2 hours, even for elective procedures. Training and accreditation, unless you have a full-time staff, leave the accreditation to the responsibility of HOD. Make them responsible to ensure their doctors who do sedation are trained and accredited, and that regular updates are made to the sedation registry. Now, to share some of our training, my time, it was see one, do one, teach one. I was quite surprised that even 15, 16 years ago, it was see two, do two when it came to teaching the residents and the medical officers sedation management. So we decided that we needed to streamline sedation training. At the division department level, we still left the teaching to them and the supervision for hands-on sedation. We do provide customized sedation modules, like in the Department of Diagnostic Imaging and Intervention. Because the residents come from the adult hospitals, we needed an additional sedation module to bring them up to speed. At the hospital level, it's compulsory. They have to undergo all this and then do an online sedation MCQ. And once they have passed, print the certificate and give it to the secretaries of the respective departments to upload onto the registration registry. The nurses, there's a sedation orientation for new nurses. And every 2 years, the nurses in the KK Children's Tower have to undergo a competency checklist. 2 years ago, we started a pediatric sedation advanced life support course to enhance the safety, to ensure at least one member of the sedation team has some advanced life support training. This is a half-day program of the Pediatric Sedation Advanced Life Support that we started in 2017. This is the customized sedation module. So the MCQs be slanted towards, the diagnostic imaging kind of scenarios. We trained a pool of nurses to be able to, do the competency checklist. And this is a competency checklist that every nurse has to undergo every 2 years. We also do team training in medical simulation, whether it involves sedation scenarios or otherwise. And we like to have doctors, nurses, even audiologists, because some of the children, even though they're under minimal sedation, sometimes the nurse cannot stay in the room. So the audiologist would need how to assess the child for their airway breathing and to be able to understand the pulse oximetry reading. I think the nurses are the pillar of any hospital. So I believe in empowering the nurses. You train the nurses to be patient advocates, to speak up for patient safety, and they are your constant pool, because residents rotate through, residents become senior and no longer do sedation management. So just don't show your appreciation only once a year, show it at every opportunity. Our sedation practitioners are mostly safe, but sometimes we do have the odd one, odd resident or medical officers that's slightly sloppy, take shortcuts, perhaps clueless, don't do documentation well. This is an example of a baby who the resident actually, passed and said safe to do sedation, but the nurse called me up and say, I don't think this is this. Can I say no? And I said, yeah, I think you should just say no. And then this baby was then referred to, to more senior people for assessment. But you have to get their trust. So if the nurses do call you, you should be available if they seek advice. And if the advice has been taken together with you, you should back your nurses in their decisions. The nurses need to know too, isn't it, whether the doctor is accredited. So the sedation registry should be in a location where the nurses can get access to it. This is available in most of the computers in KK Hospital. Tracking adverse events. I think anesthetists, we had probably about 30, 40 years of, reporting critical incidents, discussing it. But it is a fairly new culture to other departments. And with it, it was very valuable because you could see we dropped from 7% to 2%. This is excluding children's emergency audit. And there was one area where I think it was the adult endoscopy suite, and we're getting returns of 75% desaturation. So we went down to explore what was happening, and we found that all the patients, though turned laterally, were still lying on the pillow. The KK pillows are very firm, so when the IV sedation is given, most of the heads flop forward and their airway obstructed. So we told the nurses, why don't you either remove the pillow or you do extend the head before you give the sedation, and that dropped right down to 0. So I think it's important we actually, pass this message to the other departments that that it's important to have an audit culture, to have an open discussion in learning. And in fact, many of the adverse incidents are now used by the PEDS medical department for interactive case discussions during their training modules. Now, some new challenges, the ITH. It's pretty good, but it was the end of the hard copy. Remember, everything was on the hard copy, especially contraindications. It was on the first copy that the medical officer and the nurse sees. But now you have to tap one button to get to the contraindications. And if that junior doctor decides he knows it all, he might not even tap the button. And furthermore, what was one complete sedation document is now in separate locations. And that has resulted in incomplete documentation, missing data, and we are now dependent on the IT for collation of data. It took us about 1.5 years to slowly get it back on track, but it was a painful 1.5 years. So what is a path to safe sedation? I think you need to engage all stakeholders. I believe in establishing relationships, and that's how you can engage them. Maintaining momentum, 16 years later, I can tell you it's very difficult because after all, many of us hold many hats, and to be able to anticipate and address obstacles together instead of waiting for them to come. We've not been so successful, but we'll still try. Still ongoing challenges. I think we should also support, think strategies, behavioral interventions to do without sedation if possible, to reduce the need for sedation in non-painful procedures, to reduce sedation times and doses in painful procedures. So this was actually launched by the MRI staff. We do not have the proper model. This is just mini toy models, but it does help the children and the accompanying parent what to expect, because we have on speakers the loud noise to subject the kid to the real noise that they will be able to hear when they are in the tunnel. These two photos show phase 1 of the procedure, where it's essentially not painful. So through videos, music, games, we're able to engage them. And then when the painful procedure phase 2 starts, then we start the sedation. We also have an active program, especially in radiation oncology, where if the parents are keen and motivated, we actually have a program together with the Children's Cancer Foundation, the radiation oncologist technicians, where they practice, taking the child through the various phases. And in fact, this is a 3.5-year-old child from a foreign land. She speaks no English, the dad speaks no English, but with the help of and the patience of the radiation therapist and the Children's Cancer Foundation, after 5 sessions, she was able to undergo the radiation oncology with no sedation. So with this, I end my talk. I'd like to thank you again for sharing your Sunday with us, and also to my KKH Sedation Committee members, and to Jackie, my Secretariat and Memory Bank. With this, I thank you.
Thank you very much, Agnes, for your very valuable talk. I think it is very difficult to summarize your many years work into 15 minutes webinar talk. And we'll save all the questions to the end of the webinar. Our next speaker is Professor Kira Mason. Kira Mason is Associate Professor of Anesthesia from the Harvard Medical School. She is a passionate pediatric anesthetist who has spent a lot of her time in pediatric sedation. She is the organizer of the pediatric sedation outside of operating theater from the Boston Children's Hospital. Also, she has a lot of publication on pediatric sedation topics. So without further ado, I will pass the time to Kira. Thank you. Thank you very much, Kira, for your very lovely presentation on TCI in children for pediatric sedation. So I'm sorry that it is quite technically demanding for us to run this webinar. I forgot to introduce myself. I am Vivian Yuan. I come from the Hong Kong Children's Hospital, and my special interest is in pediatric anesthesia. My co-moderator is Dr. Evangeline Lim. She is a consultant from the KK Women's and Children's Hospital. And today, our third speaker is going to be introduced by Evangeline Lim. Thank you.
All right. Okay. Thanks very much, Vivian, for the introduction. Okay. So it leads me to introduce Dr. Angela Yeo, our next speaker, to you, and she'll be speaking on the topic of sedation for children in critical care units. Dr. Angela Yeo is a consultant anesthesiologist, as well as a pain specialist. In fact, she's actually the director of the Children's Pain Service at KK Women's and Children's Hospital in Singapore. She also happens to be the vice president of the Pain Association of Singapore. And she did actually a year-long fellowship at Royal Children's Hospital in Melbourne in pain. So without further ado, Dr. Angela Yeo, please share with us your knowledge.
Hi, thanks very much, Evangeline, the introductions, the kind introductions. I'm just going to share my screen now. Can everybody hear me?
Yes.
Yeah, yes. Okay, excellent. Okay, so there we go. Okay, so good evening, everyone, to this evening's talk. My name is Angela, pediatric pain physician and consultant anesthetist, the Department of Pediatric Anesthesia in KKH. And I'm very honored this evening to be able to share with you a little bit more about what our department does in tandem with the Children's ICU with regards to pseudoanalgesia and weaning. So a lot of the time, sorry, this is not working. Okay, so a lot of the time what happens is that when we are called in to help with the ICU, we feel a little bit like Prince Charming, and in the ideal world, this is how sedation and weaning would work. You kiss the sleeping beauty and the beauty wakes up and voila, that's it, no other issues. All right, but we happen to know that that's not exactly the case with pediatric sedation and weaning. This is a typical case vignette, so a typical referral that our service would receive for children in the ICU when they ask us for help with weaning. So you have, in this case, an ex-premature baby of 24 plus 6 weeks who's currently at a corrected age of 44 plus 1 weeks. She is currently post-op day 1 of a tracheostomy because she has ventilator-dependent chronic lung disease on a background of also having bilateral cleft lip and right cleft palate, so some airway issues there. This child is currently on Precedex, which is dexmedetomidine, and on morphine. And they'd like our input on the pain management of this baby because this child already preoperatively was known to be labile and agitated on handling. So how would you approach something like this? We'll look at it in a while, but in the meantime, this is why we are so concerned and why they refer to us for help. So iatrogenic withdrawal syndrome is actually something that has been more recently seen in the literature. And it really is a combination of autonomic dysregulation, CNS arousal, and GI symptoms, which occur on abrupt discontinuation or rapid tapering of opioids or benzodiazepines, which are obviously the sedative medications of choice in most ICUs. In fact, this systematic review just came out this year in Drugs, and it looked at strategies for prevention and treatment of IWS in critically ill children as well as in adults. Now, who is affected? So we're looking at risk factors here. In general, the critically ill patients receiving continuous opioids or benzodiazepines. And you'd be surprised, depending on the literature that you read, you see that maybe even up to 100% of pediatric patients in the ICUs can be affected by IWS. And another risk factor in particular is length of therapy. So if you have a child on a sedative, continuous sedative for more than 9 days, your incidence of withdrawal is actually increases up to 100%. Other risk factors include the cumulative dose and a lack of sedation management protocol in the ICU. So the question is, why bother, right? And we bother because these children are then subject to a prolonged duration of ventilation. They're subject to a prolonged ICU and hospital stay. And sometimes we end up having to use additional drugs such as antipsychotics in such children. But really, in the short term and acutely speaking, we do it because agitation from various causes can result in hemodynamic instability and collapse. So it's no wonder then that in the ICU, you would err on the side of caution and heavily sedate the child, which then leaves weaning up in the air. So this is our CICU's sedation protocol, which they have shared with, allowed me to share with everyone. In general, what happens is all intubated patients, barring some who are excluded, are given a sedation protocol for which they have set sedation and analgesia goals. And they do have provisions for purges of either morphine or midazolam based on how painful or scary the procedures the child might undergo. And subsequently, if the child is for extubation, then they will come off the midazolam and reduce or take off the morphine prior to extubation. But if the child is at moderate to high risk for withdrawal, and their criteria for that is more than 5 days of continuous exposure, then they go on to their sedation weaning protocol, which I will share with you here as well. So this is a very busy looking slide. What happens is it helps the ICU residents to risk stratify their patients and then put in place some weaning practices. Having said that, a protocol is a protocol and not everybody kind of falls within neat boxes. So one size doesn't fit all, and some children do need a little bit more bespoke care. So when we talk about bespoke care and we talk about us being the Prince Charming that comes to fend off the dragon of withdrawal symptoms, we need to know what we're guarding against, and we need to know what our shield and our sword is going to be. So with withdrawal symptoms, when we talked about CNS irritability, GI disturbances, and autonomic dysfunction, and a poor organization of sleep state, what you'd expect to see is irritability in the child's poor sleep patterns, tremors, muscle spasms or hypertonicity, and with GI disturbances, you get things like diarrhea, you get gagging, you get uncoordinated suck or swallow, and with autonomic dysfunction, which can be quite common, you get low-grade fevers, you can get hypertension, tachycardia, you can get tachypnea, you have increased secretions or sweating, you get yawning. And with the benzodiazepines, in fact, and in addition, you actually get seizures as well, so you have to be really careful with benzo weaning. So this is our approach that I'm sharing with you. Everybody does it slightly differently, but in general, what you would want to do is you would want to look at relevant medical problems, particularly those affecting your respiratory or cardiovascular system. We look at any history of recent painful procedures or operations. We look at a history of difficult weans before. We look at the duration, type, and maximum dose of opioids or benzodiazepines received. And then we look at what would the kind of stimulus that's coming in the near future. So whether or not they have any planned procedures, like a chest tube insertion or any operations. We look at and frequency of noxious stimulus. So don't forget, in an ICU intubated patient, noxious stimuli can be things even as simple as suctioning of the ETT or the oral pharynx, dressing changes, even handling in little babies, and that's quite noxious to them. So what you need to know is the as the specialist attends to, is you need to know what actually happens with the agitation. Does the baby desaturate? Does the baby desaturate to the point where there's bradycardia and there's collapse? Because this gives you an idea of how tightly you need to titrate your medications. So it would be good to talk to your ICU colleagues, find out what their sedation target is, look at frequency and triggers for agitation. Some of these kids are awake all night and sleeping in the day. You look at intervention that's required for resolution, because sometimes just the non-pharmacological patting works for the baby. And you look at any side effects for any pharm intervention that has been tried and has been given. You also want to consider the child's pain and any of the withdrawal symptoms, even at baseline when you first see the child, because the ICU might have already tried. And then logistically speaking, and for planning's sake, you want to know about oral intake, or NG intake. You'd ask about fluid restriction and when the lines are due to be changed. And finally, the decision really is baseline sedation adequate? Is sedation on handling adequate? So these are the few scales that we use in the ICU. I won't go into them in great detail, but for the sedation scales, we use SBS and the NPAS. The pain scale, we generally use the FLEX scale. And for weaning scales, we use the WAT1 or the modified Finnegan, depending on CICU or an ICU. So either the children's or the neonatal ICUs. And all these scales actually have been validated in the pediatric CICU or ICU populations for intubated children. So the general weaning principles, in general, the longer a child has been on a particular drug, the longer it will take to come off that particular drug. So be patient. You can reduce the dose by 10 to 20% a day, and you hold the wean at that dose if the WAT1 score is more than or equal to 3, because that would indicate some degree of withdrawal symptoms becoming very uncomfortable. And in order to deal with the withdrawal symptoms, we can give PRN doses of either the opioid or the benzodiazepine, or you can allow NCA, so nurse-controlled analgesia boluses, and we'll talk about that later. We do generally tend to use clonidine, and I'll talk about that as well later, but we tend to keep the clonidine till the last, until you've actually come off everything else. And then you've got to decide also if there is going to be a noxious stimulus. Now, if there is very minimal to no noxious stimulus, it should be a straightforward wean, but it can be difficult if there's frequent noxious stimuli, such as if the baby is very secretory and there's a lot of suctioning that's required. Then you need to consider as well whether opioids will be required. Now, usually what happens is if your stimulus is predictable, then you can use something and preempt the stimulus. If the stimulus is unpredictable, for example, then you may need to maintain a baseline level of analgesia. You may need to rotate opioids in order to reduce your overall level of opioid use. You may need to consider using an alternative drug, and you may want to consider using an adjunct. So the common drugs that we use in our practice is morphine. So we use that either as infusions, plus minus NCA function. We use ketamine as well. With our benzodiazepines, in general, our ICU uses midazolam for the infusion, and then when we convert, we go either to IV Lorez or more commonly an oral lorazepam. We also use clonidine and dexmedetomidine quite a lot in our sedation in the ICU. And sometimes we use chlorpromazine. So these are in general our sword and shield against withdrawal. So just a bit of a rehash. So for sedation, to keep our kids comfortable and sleeping, opioid, benzodiazepines, ketamine, alpha agonists, as well as chlorpromazine. And to deal with pain, opioids, ketamine, and alpha agonists. And when we're talking about weaning, we use the NCA modalities very frequently, and we use clonidine to kind of stave off the sympathetic symptoms. So how we use our nurse-controlled analgesia, we use the normal sort of CADD Solis pumps. So we use these, we have a protocol for this written up for the nurses as well. We either use morphine or ketamine or a mix of both. So it's not unusual to actually have two pumps by the bedside sometimes. And we kind of have default prescription whereby it's 1 times body weight in 50 mils because that gives you 20 mics per kilo per mil, and the bolus is usually 1 mil maybe every 15 minutes with a maximum of 5 mils per hour. Of course, this means that you need to and assess the efficacy of each bolus, and you may need to either increase the bolus size or shorten the lockout interval depending on how the child is responding. to each bolus. In general, if the kid has been on an infusion, then we wean the infusion 10 to 20% daily, or as tolerated, sometimes a bit faster if they can, or slower if they cannot. And then rescue doses are given to manage withdrawal symptoms. Ketamine, in our practice, we actually use two different dilutions. One, which we call the ultra low, is actually the same as morphine, so 1 times body weight in 50 mils. And then there is a low dilution whereby it's 5 times body weight in 50 mils. You can get better, you can opioid spare a whole lot more with your low dose, but be warned that you can also get dysphoria above 150 mics per kilo per hour, and that can be quite distressing, particularly to the older children. So the younger ones can't speak of it. The older children may get hallucinations, which can be very, very unpleasant. So just bear that in mind. When we use midazolam and lorazepam, what happens is that what you will see in the literature, and kind of if you Google it online, there really is an overall lack of evidence to support specific conversions. Also contributing to that is the lack of kind of FDA oversight. So with the variance in bioavailability, duration of action, patient factors, you'll find many different bioequivalent tables out there for your benzodiazepines. In general, well accepted would be a IV midaz is to IV loraz ratio of 2:1. Or we take the total IV midazolam dosage over 24 hours and multiply it by a factor of 0.2 if you want oral lorazepam, and then just divide that into 4 doses. Clonidine and dexmedetomidine are really very lovely drugs. They are alpha agonists. They're used more commonly as adjuncts, and they can be opioid sparing. But the issue is that they may cause hypotension and bradycardia, so be very careful with them. Just note that last I checked, dexmedetomidine is not FDA approved for pediatric use, so there's obviously a lot of off-label use, but their product insert still actually hasn't included it. It can be infused at 0.2 to 0.7 mics per kilo per hour, up to a maximum, I think, of 2 mics per kilo per hour. At least that's our top limit. Because we've seen quite a fair bit of hypertension and bradycardia in the very young or in the critically ill ones, particularly those of hemodynamic instability in the ICUs. You can get withdrawal symptoms from dexmedetomidine. Most commonly, of course, the agitation, fever, vomiting, loose stools, decreased sleep. So typical of withdrawal to any drug, and your risk factors for that include your peak doses, your cumulative daily doses, and the duration of use of more than 72 hours. So there have been 2 cases flagged up by the FDA for deaths due to Precedex in pediatrics. Having said that, the first one was a 10-year-old with a history of Rett syndrome, which is associated with cardiac arrhythmias, and the second one was a 15-day-old, really premature baby with lots of comorbidities. So it's hard to say really that it was Precedex, but it's just a reminder to be careful and respect the drug. I actually personally prefer clonidine when I am working with these ICU patients that need weaning, in particular because it's great for sedation, but it's also great for ameliorating your withdrawal symptoms, and it's very flexible because you can give IV infusions, you can give it as IV intermittent boluses, you can give it orally, you can put it down in an NG tube, and it is much cheaper than dexmedetomidine in our setting, particularly when we transfer cost to the patients. So it really depends on your healthcare setting. So as a clonidine infusion, we tend to run it at 0.8 to maybe 3 mics per kilo per hour, or oral doses can be anywhere between 1 to 5 mics per kilo every 4, 6, or 8 hourly. And then you daily taper down to 1 mic per kilo 6 hourly and increase your interval over 7 to 10 days once you've weaned your child off your opioids and benzodiazepines. So again, you have to convert between dexmedetomidine and clonidine, and there aren't many conversion tables out there. Usually the practice would be to wean your dexmedetomidine down to 0.5 mics per kilo per hour, and then after that sort of overlap with your clonidine. So you can start your clonidine anywhere between 1.5 to 2 mics per kilo every 6 hourly, and then take your dexmedetomidine down by 25%. So by the end of one day, by the end of 24 hours, it should all be off and your clonidine should be running, and then you can titrate downwards. So if we go back to the case vignette that I showed you just now, how would we manage something like this? Basically what happens is we would see the relevant medical problems, so the premature status, the chronic lung disease, and then with regards to history of recent painful operations. She is POD1 tracheostomy. That wound's still going to hurt. They are on dexmedetomidine and morphine. We know how much they're running, but you do have to see how long this child has been on it and how high the doses have been, because you know that they've probably been using it preoperatively as well when the child was labile and agitated on handling. So there are a lot of questions that we will still have despite this referral letter. So it deserves a conversation. So you need to see the child, and it deserves a conversation with the ICU specialist to really see where they want to target sedation for this child and how fast they need to wean this child. And really, sometimes it's not up to them, it's up to the baby. So that's about all I have on this topic. I'm not sure exactly how many of you in the audience would be involved in these sort of cases, but if you have any questions, feel free to ask me later in the Q&A or just email me. Thank you.
Right. Thank you very, very much, Angela. That was a really interesting talk. So like Angela kind of mentioned, okay, if there are any questions, okay, please feel free to type in the Q&A. Okay, without further ado, let me introduce our last speaker for today, Dr. Vancy Kwok. Dr. Vancy Kwok is actually an associate consultant with the Hong Kong Children's Hospital, and she has got a special interest in pediatric sedation. And this interest has actually seen her assume the chairmanship, okay, of the Sedation Task Force Committee of Hong Kong Children's Hospital, as well as Safe Pediatric Sedation, okay, which is actually a simulation training for sedation of children undergoing diagnostic as well as therapeutic procedures. And this is actually jointly organized by the Hong Kong Colleges of Anaesthesiologists, Pediatricians, as well as Pediatric Nursing. So without further ado, can I invite Dr. Vancy to proceed with the talk, please?
Thank you, Dr. Evangeline. Okay, firstly, I'd like to share my PowerPoint first. Can you see?
Yes.
Okay, good afternoon, everyone. Today, I'm very honored and grateful to meeting you all online. With the gathering of brains today, I'd like to take this opportunity. In the comment section, I'm going to invite all of you to share with us your opinions and views. I'm going to share a challenging patient in pediatric sedation in this coming session, and I'd like to invite you all to vote in the polls that which I'm going to put up on later. Okay, for this patient, he is a 4-year-old boy diagnosed with mucopolysaccharidosis type 4A last year. He was presented with short stature and bony deformities and was then put on enzyme replacement therapy. Recently, it was noted that he developed brisk reflexes and ankylosing, and therefore urgent MRI brain and whole spine with contrast is asked and sedation is requested. Well, a very brief revision about MPS 4A. MPS is an autosomal recessive lysosomal storage disorder, and patients have a defective gene in the enzyme N-acetylgalactosamine 6-sulfate. And this results in problem of breaking down and therefore accumulation of two types of glycoaminoglycans, namely keratin sulfate and chondroitin 6-sulfate. And a lot of mutations has been reported, and the clinical presentations can be very variable and wide, and the incidence is not very common. As anesthesiologists, we probably would be most concerned about the airway of MPS patient because it can be up to 44% of them having difficult intubation. Frequently, they have tracheal narrowing, short neck, and they can be complicated with some respiratory diseases as well, and that can further complicate the clinical picture. Secondly, for MPS 4A in particular, they have a very prominent skeletal involvement. And the most worrying one would be the failed ossification of dense and dense hypoplasia. And this results in the risk of subluxation and the cervical spine instability. To diagnose cervical spine instability, X-ray is, of course, probably the most easily available modality. The atlantodental distance or the predental distance is our point of interest. And anything beyond 5 mm will be considered abnormal for kids. Unfortunately, X-rays can be quite difficult to interpret because the predental space can be obscured by the delayed ossification of the dents and also the superimposition of the mastoid processes. And therefore, MRI remains the most useful tool for assessment. MRI can confirm the cord compression, judge the severity, and also monitor for the presence of cord injury. And it is very essential for clinical surveillance and pre-surgical planning. And so right now, here goes my first question for everyone. For a 4-year-old boy now coming to you with MPS 4A, and he needs an urgent MRI brain and spine with contrast, how would you sedate this patient? Okay, so it seems like a tough battle between desmetanide and ketamine, and some of us choose chlorohydrate, benzo and propofol as well, and some may opt for general anesthesia. So maybe we can stop. Can we stop the? Yes. Okay. Well, desmetanide seems to be favored by most of us, and it is not surprising because desmetanide, especially for this last decade, has been very popular among pediatric anesthesiologists because it can mimic the natural sleep and has minimal effect on respiratory function. And in fact, I tried to dig, and desmetanide is a highly selective alpha-2 agonist, and it has minimal respiratory depression and also have some analgesic effect. And this is a study published by our fellow speaker today, Dr. Mason, quite some years ago. It shows that it is possible to use a SOAP regimen for using a desmetanide, using it for the 3 mics per kilo, and then followed by an infusion of 2 mics per kilo per hour, resulting in 97% of successful sedation with minimal hemodynamic effects in pediatric group of patients. So I dig into the literature and try to see if desmetanide or propofol or anything else can be an answer to my patient. Is it good to use desmetanide or is it better to use something else? The literature is in fact quite limited. This is a study conducted by the Korean group 2 years ago. They compared propofol versus desmetanide for MPS type 2 patients. And they recruited 27 patients and they compared propofol infusion versus desmetanide infusion for sedation. What they found is that for the desmetanide group, it has far less artificial airway interventions. But the onset of sedation, duration time, the time to awake and time to discharge time are quite comparable between the two groups. So it seems that desmetanide is a more preferred agent for use in the very limited number of patients, of MPS patients. So another group of experts in Ohio in USA, they also explored the use, but this time they combined propofol with desmetanide for the MPS-free patients undergoing MRI and lumbar puncture. The patients are first induced by sevoflurane for IV setting. Although upper airway obstruction is detected in 1/3 of the patients during inhalational induction, and this requires CPAP airway support or repositioning, the airway dynamics improved after changing to IV anesthesia with desmetanide and propofol. And yet, still 26% of them, these are simple shoulder roll to support the airway, and desaturation is detected in 3 patients. But mind you that for MPS type 3, it is quite special because the somatic and airway involvement are not that severe compared with MPS 4 or other types of MPS. So what we did in Hong Kong children in the end is we chose desmetanide. Well, we pick intranasal desmetanide, we give it 3 mics per kilo to the patient, and at the same time, we apply amla to his hand dorsums. The patient begins to sleep in 20 minutes, and we continue the sedation after establishing the IV and continue with IV desmetanide at a relatively low dose of 1 mic per kilo per hour. The scan is completed in less than 2 hours, and the neck is maintained in neutral position, and there is no desaturation in between. Intranasal desmedetomidine is our agent of choice in our Hong Kong Children's Hospital. It is quite easy to administer, and most kids find it tolerable. Well, this is a Hong Kong study conducted by Dr. Vivian Yun, and what they're trying to do is trying to find the onset time of the intranasal DEX. It is found that nearly over half of them will be sedated after 30 minutes after administering 1 mic per kilo of desmedetomidine. So what they do subsequently is they conducted another study, and this time investigating between 2 and 4 mics per kilo. It seems that the 4 mics per kilo desmedetomidine has a shorter onset time, and with the onset time of around 17 minutes only. And for 2 mics per kilo desmedetomidine, it only needs 25 minutes for the onset time. So eventually, we have the MRI report of this patient. It is found that he has diffuse spinal stenosis at C2 to C5, with flattening of cord at C2. There is also some features suggesting of myelomalacia at the C2 level. Therefore, the metabolic team and orthopedic surgeons now request, can we do an MRI brainstem and craniocervical junction MRI with a flexion and extension view? And they want this appointment to be 3 months later. Okay, and as anesthesiologists, what will you worry about? Well, for the metabolic group of people, they actually have recommendations published last year. For MPS IVA, it is recommended that MRI needed to be performed every year to every 3 years. It is essential for clinical surveillance and also for pre-surgical planning of the cervical spine stability. Surgery may be needed in this group of patients. And flexion and extension MRI may be vital because it can show more cord compression or instability than the neutral scan. However, as an anesthesiologist, probably we will be very concerned because the duration can be long, and therefore sedation is probably needed. But however, with the patient sedated, and also we need to manipulate the neck, the patient may have the risk of subluxation, spinal cord instability, and cord compression. It is impossible for us to monitor the neurological status after the patient is sedated or anesthetized. And with the tracheal narrowing, the anterior buckling of the posterior tracheal wall may further obstruct the airway during the flexion. In fact, according to traditional teaching, it would be ideal if the patient can voluntarily flex or extend their own neck. And it is never advisable to manually flex or extend the patient's neck when they are asleep. So this comes to my second question of the day. Will you sedate a child with MPS IVA, just 4 years old, for flexion extension C-spine MRI? So it seems the vote is quite exciting. Nearly half of us wish to go, more than half of us wants no. But about 44% of us still wants a yes, still wants to proceed with the sedation. After all, it's quite difficult to do an MRI without sedation for a kid, just 4 years old, right? But it is indeed very risky. So my question is, how can we do the MRI flexion extension view for this patient? Excuse me. Okay. So this is a study conducted by the McKenzie and his colleagues. This study shows that what they did is they tried to do the GA or sedation and study 38 patients undergoing MRI flexion extension scan of the cervical spine. All these patients have craniocervical instability. They invited on-site radiologists to monitor and position the patient, while the anesthesiologist monitored for any airway compromise. Flexion and extension MRI, however, proves to be very useful after this study, as it can evaluate some dynamic change in the cord diameter or any cord compression. And in fact, there are nearly 1/3 of them has a change of interventions after completion of the flexion and an extension study. And all procedures are done eventfully, and there's no documented change in neurological examination after the MRI. Another group by the Stanford colleagues, Dr. Yassis and his colleagues, they studied 45 patients in 66 scans, and also they have cranial and cervical instability. And they also do the flash and extension scans, and this is monitored by the neurosurgeons first. They did a physical examination, and during the scan, it is monitored by the neuroradiologist, and they gently manipulate the patients during the sedation, and there's no neuromonitoring during the procedure. Again, they found that it is successful. However, this is the number of the population of the sample size is very small. Although it seems possible, although sedation seems possible, it is still definitely controversial. So my question is, can there be other options? Well, finally, in Hong Kong children, what we do is we try to train our patient to be awake for the MRI. We involved our metabolic team, orthopedic surgeon, physiotherapist, radiology department, and also child life specialist. This is the MRI scan room in our hospital. And this is the MRI simulator, what we call it mock scanner. We usually use this mock scanner to evaluate if the patient can undergo sedation or no sedation for the MRI. We'll ask the patient to go inside, and the machine can generate some noises, which can mimic the actual MRI scan. And then we'll try to involve the child life specialist, and then they will try to help the patient to embrace the experience of MRI scanning. Well, this is possible because we have the luxury of 3 months' time before the actual scan. And we are very fortunate to have the supportive staff from all departments, the metabolic team, and also orthopedics and the radiologists to help us in this process. And we also discussed with the radiologist on how to position the patient during the scans. We modified the imaging sequences so that we try to limit the manipulations as few as possible and limit the time as short as possible, and focusing only key areas of concern. And the radiology team and the anesthesia team will also be there during the scan and monitoring the patient's condition and also respiratory status. So summarizing, whether we should give sedation for patients with known craniocervical instability to undergo flexion and extension view of MRI, this is a controversial topic. Published literature is very scarce. However, it seems it isn't impossible. Proper physical examination and documentation before and after the procedure seems to be essential. And during the sedation, choosing a respiratory sparing sedative like desmodetomidine can be helpful. Desmodetomidine seems to be a reliable choice. A joint discussion and co-monitoring with radiologists and anesthesiologists will be beneficial, and with modification of imaging techniques and also with mock scanning training. We aim at identifying the goals of imaging before the procedure and also limit the time of procedure. So this is the end of my presentation. Thank you very much for listening. And I'd like to give my special thanks to Dr. Bella of the metabolic team and also Ms. Poon, the radiographer of the radiology team. Thank you very much.
Thank you very much. Can everyone hear me? Okay, thank you very much for okay, thank you very much for Vancy for your very informative talk on the challenging case. This has concluded our session, and then we have maybe about 20 to 30 minutes for question and answer. So some housekeeping rules for the question and answer. The chat and raise hand function are disabled. You should have already sent in your questions and comment via the Q&A, and we will try and respond as far as we can. So some of the question has already been answered in the answer session. And then we will answer some of the other questions here live by our speaker. Can Viva, okay, sorry, I should stop sharing. Okay, so the first question is for Dr. Agnes on sedation protocol.
Oh, about sharing the sedation protocol.
Able.
It's many pages, you know. But what I can do is I can give you the categories, and I post it on the ASPA website. But you really have to fill in the blanks yourself, because it depends on how strict or how, you know, flexible you want to have in your respective institutions. So I will do that. I will trim it such that you could see the broad categories and include some of the annexes, and I post it in the ASPA website.
Okay, thank you very much. I think there is both question for you was on protocol, but the second question is for protocol on endoscopy.
Oh, okay. I omitted that endoscopy I was talking about was for adults, but in the pediatric, you know, we the teachers do manage the endoscopies. So that example I gave was for adult endoscopy, where moderate sedation is given by the endoscopist and monitored by the nurses in the day surgery operating theatre. So my apologies for not making it clear.
Okay, and then we have a lot of questions for Kira on sedation. The first one is the question on the reliability of BIS on pediatric population. Will Kira be able, or any other speaker be able to respond to this question? Thank you, Kira.
Hi. So dexmedetomidine for sedation.
Can
you hear me?
Yes, we can.
Can you hear me?
Yes, we can hear you.
Can you hear me?
Yes, good. We can hear you.
Can you hear me?
Yep.
Yes?
Yes, can hear you. Yes, good.
Okay. Can you repeat the question? My audio just went out, sorry.
Okay, so the first question is the reliability on of BIS on small children, I think.
Okay. So there's some published literature along with my clinical experience that indicates that BIS monitoring is reliable up to the age of 1. So from age 1 upwards. But, you know, as with any BIS monitoring, sometimes you can be surprised. This week I had a patient who had a BIS of 40 and there was no change in stimulation. Then all of a sudden they aroused. So especially if you're not doing target controlled infusions and you're just doing total intravenous anesthesia, where your depth of sedation or anesthesia could be changing if you're doing intravenous infusions, you just need to consider that. But I use BIS all the way down to age 1.
Right. So there is another question on BIS also. Do you think the signal or the EEG signal from dexmedetomidine is different from the other agent, and would you use BIS on dexmedetomidine sedation?
Definitely I use BIS for dexmedetomidine sedation. I actually would use it even for sedation involving ketamine. And I find that, for example, the autistic patients that I might pre-medicate with intramuscular dexmedetomidine and ketamine, which I do in small doses, I find that even in those patients that the BIS is reliable.
Right. So there is another question on the dexmedetomidine. So when you do dexmedetomidine sedation, or perhaps dexmedetomidine combined with propofol, would you pre-medicate the patient with anticholinergic agent?
Right. So definitely there's data to support. We also were the first to publish that in the presence of dexmedetomidine, hypertension. And to date, there is no published study that shows that the drop in heart rate and blood pressure that you can get with dexmedetomidine is of clinical significance. So in other words, you can expect that you can get a drop in heart rate and blood pressure with dexmedetomidine up to maybe 20% or 30%, similar to what you can get with propofol. However, this is clinically not significant because it doesn't need treatment. However, because you need to remember that there's a biphasic effect on the blood pressure with dexmedetomidine. So even though the heart rate might decline, when you get higher serum concentrations of dexmedetomidine, your blood pressure is going to go from a low blood pressure from the alpha-2 agonist effects to an elevation in blood pressure because of the alpha-1 effect. So the only way that you can get hemodynamic instability with dexmedetomidine that needs treatment is really if you overdose the patient. That meaning that you don't appreciate the synergy that dexmedetomidine creates. So if you keep your sevoflurane high or keep your propofol high or give too much narcotics, or if you have a hypovolemic patient, then of course you're going to get a drop in heart rate, a drop in blood pressure, but that's not because of the drug, that's because of the user.
Okay, thank you very much. I think I pass on the second part of the question.
Does that answer the question?
Yeah.
Okay.
Yeah. I agree with that too. So I will pass on the second question and answer session to Evangeline.
All right. Okay. All right. Thanks very much. Okay. I think the Vancy has actually received quite a few questions with regards to sedation and MRI. One of the questions pertain to why the use of intranasal dexmedetomidine, and also how would you actually administer intranasal dexmedetomidine?
Okay, we use intranasal dexmedetomidine because it is quite easy to administer. We usually use a atomizer, a commercially prepared device connecting to a 1 ml syringe and then we inject the patient into the patient's nostrils. And most kids can tolerate it quite well, and usually they can fall asleep very soon, after within 30 minutes. And also, it is because it's easy to administer, so easy. And also, there's less first-pass effect as compared with oral. And the patient can be sedated before the IV setting, and most parents find it more, easy to accept.
Right. There is also an additional question that if the patient had actually some URTI or nasal secretion, would that affect the nasal administration of dexmedetomidine?
I think it might affect because sometimes they may sneeze, and also the absorption may not be totally reliable. In that case, you may need to titrate your route accordingly. Sometimes you may need to choose other routes of administration.
Right. Okay. Thank you very much. There was an interesting question earlier on, okay, by a participant who actually asked, okay, that, very often chlorohydrate sedation actually fails for somebody going into the MRI, okay, and asking them, okay, if you actually rescue them with IV midas and IV morphine and it still fails, would you be able to suggest anything else that will actually enhance the successful sedation of such a child, okay, without having to cancel the procedure because of failed sedation?
Well, I think that chlorohydrate, I agree that sometimes it does fail because it cannot work. It doesn't work that well for older kids, more like those who are about 4 years old. And also some of them make vomit and have gastric upset after taking the chlorohydrate, and then resulting in you actually lost some chlorohydrate during the vomiting, and sometimes it leads to redosing and results in excessive
Could I make sedation. A comment about chloral hydrate?
Yeah, sure, please. Yes, please, Dr. Mason, Professor.
Please carry on, Dr. Mason.
Yes, go ahead, please.
Okay, so, chloral hydrate actually is is not even being used in the United States anymore. And you can't even buy it at the pharmacy because the FDA has discontinued it. And there's been more pediatric deaths related to chloral hydrate than any other sedative. And I frankly just don't see how, you know, a drug that's been around for 100 years with a half-life that could be up to 24 hours is still in use. And I don't support the use of chloral hydrate at all. I know that people are still using it, but you're basically discharging a patient home with a long half-life drug that has unpredictable oral absorption. And I think that in this day and age, we should have better things to offer, like just starting an IV and giving a sedation that we know is predictable, reliable, and safe. So that's really my opinion, to be starting to do oral chloral hydrate and then to start adding Versed and start to add other medications. You're essentially giving a extremely deep sedation with no intravenous access at all, and then discharging these patients home.
I agree with you, Professor. Yes, I find that chloral hydrate is actually quite problematic with a very long recovery, very common side effects. And although it is easy to administer, but and it fails quite frequently as well. So I don't see the benefits of giving chloral hydrate personally, my personal opinion.
Right, thank you very much for sharing your answers. There's another question which basically pertains to, is clonidine a reasonable alternative to Precedex or dexmedetomidine being used for MRI sedation? What about the role of melatonin? Would anyone like to answer that?
I don't have experience yet.
I personally, I don't have experience in using clonidine and melatonin in MRI sedation. Yeah,
so clonidine really wouldn't be an effective use for MRI sedation for intensive care units that are having prolonged sedation with an alpha-2 agonist and that might not have the budget for dexmedetomidine. Then clonidine could be an alternative, or even clonidine patches. But for something like an MRI where you're trying to titrate a depth of sedation, clonidine really, there's no data to support clonidine use, nor is there really any published material on it for MRI.
Okay. And Dr. Mason, could you kind of share your opinion about the use of ketamine then as a sedation for MRI?
So, you know, I think with ketamine, you need to remember that if you're giving it alone, that you can get these, you know, these uncontrolled movements that would make an MRI scan, especially if you have one single chance to do it right with contrast, very challenging. In the autistic patient population for whom you want to start an IV to be able to establish a good sedation or anesthetic, then you could opt for some ketamine in order to sedate them adequately to start an IV. You know, in my experience, you don't need high doses. So, for example, if I'm going to do an intramuscular dexmedetomidine ketamine, and that's the combination I always use. So if I'm going to give ketamine, I always give dexmedetomidine. I don't feel that the ketamine midazolam Versed or dexmedetomidine Versed, I don't feel that Versed should play any role in an intramuscular injection. So my doses of ketamine, for example, are very small. You're talking about a half a mic per kilo of dexmedetomidine in the concentrated form, and only 1 milligram per kilo of ketamine in the concentrated form. And that really is going to be adequate. It works in about 7 or 8 minutes. It's not enough ketamine to be able to, you know, to be concerned about these little paradoxical movements. And it's certainly enough to be able to establish an IV and then to be able to move on from there.
Okay, sorry, just to clarify, just in case there's a little bit of confusion, the ketamine and dexmedetomidine preparation that you're talking about, where you talk about 0.1 mic and you talked about 1 milligram of ketamine?
No.
That's an intranasal?
Yeah.
Or that's an intranasal?
No. Intramuscular, okay, right? Because the intramuscular bioavailability of dexmedetomidine is almost 100%, and it works within 7 or 8 minutes.
Okay.
So a half a mic per kilo of dex and 1 milligram per kilo of of ketamine intramuscularly.
Okay, great. Thank you very much for clarifying that. Okay, there was also another question about any recommendations for neonatal sedation for MRI. Meaning, if you have a neonate, would you choose to sedate, or are there alternatives that you would recommend for neonates who have to undergo MRI? I think it's open to the floor. Anybody can can chime in.
Agnes?
You muted, Agnes.
Muted.
You muted.
And actually, we're not called upon when they're very confident that feed and wrap works, but they're very strict in DDII in KK. They would only choose single region MRI, that means the shorter ones. And if the babies have no significant comorbidities, then they would do a, feed and wrap. But they actually do it, not we. And if they think that it's not suitable, then we will come in. It will appear on our list.
Yeah, I would think, I think the feed and wraps, you got to be very careful in case they reflux or vomit in the scanner. When we do the feed and wraps without sedation, they all have pulse oximetry monitoring. And another option would be, instead of doing the actual feed, just put a little sugar, some sugar granules or some glucose water on a pacifier, put that in their mouth. Sometimes that's adequate also. I think if that doesn't work and the scan's really necessary, then in most cases I would consider, in a real neonate, just securing the airway.
Thank you. Okay, there's another question about, is there a role for a combination of intranasal ketamine and dexmedetomidine? So instead of intramuscular, would there be a role for intranasal?
So I think the challenge that you need to remember is that if dexmedetomidine is swallowed, it's essentially not at all therapeutic. And so if you consider that each nares, for all intensive purposes, shouldn't be getting more than 0.5 cc's maximum, I think oftentimes you're restricted because of the volume that you would need. So I find actually that, people make a big deal, and parents oftentimes think, oh my gosh, intramuscular. But intramuscular, really, where it's going, it's going to be reliable, and it's very effective very quickly. And a small 23 gauge needle is really quite insignificant. So I would most usually just go for intramuscular, because if you give intranasal and then the patient's not lying flat, and then you don't know how much is in and how much is out. So I tend to use intranasal exceptionally rarely. Vivian, what about you?
Well, we don't usually straight away use ketamine with dexmedetomidine, but we often just start off with dexmedetomidine, and on top of it, if we need to deepen the sedation or prolong the sedation, we use IV, either dexmedetomidine or additional propofol. So I think if we give ketamine in the beginning, there is a large chance of delayed awakening. So this is not our first option. Maybe Vancy or other panel can also comment.
Vancy, would you like to share your opinion?
I do not have much experience with intranasal ketamine, to be honest. But I do, as Mr. Ado, a lot dexmedetomidine intranasally.
Okay, so. Thank you. Okay, there was also another.
I don't have any further comments.
Right. Okay, there's also another clinical scenario in which if a patient has seized recently, in other words, he has recently presented with seizures and they actually want to do an MRI brain, what would your choice be? Would it be sedation or would it be general anesthetics? This is open to the floor, to the whole panel.
would Angela be helping to comment? You have to mute.
Okay, so Yvonne, the question was, with a patient who has seizures for MRI, would you prefer to sedate or GA the child? Okay, well, I guess it depends on the seizures and how frequent they are and how acute they are and how expected they are or are not. But I would say that in a case whereby the seizures are fairly unpredictable, very acute, and the patient's already been compromised, I think the reason they're getting an MRI is they need an answer. So if there's a likelihood that kid, still seizing during an MRI and not actually giving you a good good picture, I would actually prefer to give the kid a GA. But if it's just a one-off and the child stops seizing and it just sort of, I think it's just very clinically dependent on the scenario. Yeah, so I can't say that one or the other is gonna be superior. I think it's just really clinical judgment. I don't know if anybody else has anything else to say about that.
So an actively seizing child shouldn't even go into a scanner. So there's really no place for someone who's actively seizing to go in. At Children's, we take care of children with intractable seizures all the time. In fact, part of their workup for, hemispherectomies, for example, would be bringing them in, taking them off all their seizure medicines. And then the goal is to capture them with a seizure, having just had a seizure. Both for nuclear medicine as well as for MRI, and these patients are all sedated. Don't forget, after patients seize, oftentimes they're very sedated on their own. So pretty much most of these patients just get dexmedetomidine.
Okay, all right. And when you start off dexmedetomidine in these patients, is there a particular dose that you start with? Simply because there might be a post-ictal kind of decreased, lowered conscious level.
Yeah, I mean, our doses are pretty much similar. They stay the same. So it's 2 to 3 mics per kilo bolus over 10 minutes, and then infusions of up to 2 to 3 mics per kilo per hour. Don't forget, with dexmedetomidine, there's really, if you're using it all by itself, there's no fear of apnea. Dexmedetomidine doesn't cause apnea. It cannot cause apnea. There's no alpha-2 receptors in the medulla. And it's never been shown to even get patients into REM sleep. So it brings patients to stage 2 or 3 sleep. So we're talking about the light stages of sleep before you get into REM. So it's better to get a good scan and to have a deeper sleep than it is to try to run these patients light and end up with some movement.
Yeah, I agree with that, but then we have to also be mindful that although dexmedetomidine doesn't cause apnea, but your patient might be susceptible to apnea depending on the patient's clinical state, especially if someone is post-ictal. So we still have to monitor, especially if your patient is marginal, so that like a post-ictal patient, recent seizure or hemodynamical problem. So we still have to be very vigilant.
Right. I mean, of course, all patients should be monitored, like Vivian says, when they're in the scanner. And an MRI never cured anybody. So they shouldn't go into the scanner unless they're hemodynamically and neurologically stable, just as Dr. Yuan mentioned.
Well, thank you, everyone. Okay, there is a question about, would anyone do an MRI under sedation without an IV? So either oral, intranasal, intramuscular drugs only?
Can Nancy answer that question?
Yes, we do give intranasal only sometimes for short scans and those that don't require any IV access, like plain MRI scans.
I think there's just one other question that might be of interest to the general audience at large. What about patients with cerebral palsy or global delay? Would you alter your sedation protocol? Okay, or would there be a preference for general anesthetics? given the fact that these patients may be not cooperative? Yeah.
Well, for my institution, we still give sedation for these patients because these patients can be sleeping normally at their home anyway. And therefore we would choose some respiratory sparing sedatives like dexmedetomidine usually is the choice of our sedation during the procedure. We do not give them general anesthesia simply because they have CPU or developmental delay.
Okay, so I guess our approach basically would be for any uncooperative patient who will not allow you to set an IV. The preference would be for intranasal dexmedetomidine. Is that what I'm?
Well, if they cannot allow us to put an IV, usually we give, sedate him with the intranasal route first. And then when he's sedated, we put in the IV when he's sedated.
Okay, thanks very much. Okay, there are many other questions, okay, on the Q&A part that pertain to, you know, if we were to run a propofol for MRI, what would we do? Would that all that sort of information with regards to dosages and how you actually do it be in the book that you recommended, Dr. Kira?
Sorry, I was trying to look at all the questions that are, could you just mention it again? There's
right.
So many questions.
Quite a few questions on the Q&A, which actually pertain to what dose do you give for propofol, you know, and, you know, et cetera, et cetera. So my question is, would all these information be available in the book that you had recommended?
Oh, yeah, the book. So the book is coming out in the next couple months. It's the 3rd edition. It's probably almost 2,000 pages, and there's lots of stuff there, and you can certainly find your questions answered. Just trying to go through the QA and look at a few of the questions. It seems like there's a considerable amount of questions about DEX and the route of administration. So, you know, there's a concentrated form of dexmedetomidine, 100 mics per cc. And if your patient, for example, if you're going to do intranasal dexmedetomidine, I would probably be going for somewhere like 3 mics per kilo of dexmedetomidine if you're doing intranasal. So you need to calculate it out. If 3 mics per kilo comes to more than 1/2 a cc in each nares, and certainly you can divide it up between each nares, then I would not be using the intranasal dexmedetomidine. If you're going to give intranasal dexmedetomidine, you're really talking about an infant. Anything bigger than an infant, it's not going to, you know, you're outside probably of the size that's going to work. And I usually have the parents, you can use a tuberculin syringe or you can use a mad atomizer. I think the jury's out on which is most effective, but the mad atomizers, I think in the infant nares might not even fit well. So I would just use a tuberculin syringe, not putting it up so far that it goes back into the mouth, but that it still stays in the nasal mucosa. And you basically have the whole parent hold the baby down on its back with the head flexed up. And then after you inject it, then you're going to keep the baby there with the head up for, I don't know, a good 5 or so minutes. And you'll see it start to work. It should get really have adequate effect within 7 or 8 minutes. There's been a lot of questions about the bradycardia with dexmedetomidine. And I just keep stressing to everybody that the bradycardia with dexmedetomidine is nothing to worry about as long as you are cognizant that that you don't overdose your patient with anesthesia. Don't give too much propofol, don't give too much inhalation, don't give too much narcotics. They won't need it because Dex is a synergist and it can decrease your dosing of those drugs by about 50% sometimes, which is why I feel really strongly that, especially if you're not really adept and experienced with dexmedetomidine, that you should always use BIS monitoring, because it's a really good visual reminder to you as to how little other medications that you need. If that heart rate really bothers you, don't use the anticholinergic because you can get extreme hypertension, like I mentioned. Just give a little ephedrine. That being said, even though there's no absolute contraindications to Dex, if a patient's on a beta blocker and they're blocked, or they're on a calcium channel, or they've got they've got some cardiac arrhythmia, for example, because remember, Dex decreases conduction through the sinoatrial and atrioventricular node. So if they've got any rhythms that wouldn't tolerate a drop in heart rate or wouldn't tolerate a nodal or sinus arrhythmia, which occurs in up to 15% of the patients, then I would not use dexmedetomidine.
Thanks very much. That's very insightful. Okay, Angela, just one question, all right, that someone had asked very early on. Is there a favorite drug combination for sedation and ICU that you have?
No, in general, I don't really like benzodiazepines. So when I did respond to that earlier, and I said that usually when the Children's Pain Service gets called in, they've already tried a lot of different things, but and I just have to work with what's there. But as an anesthetist, when I send a patient to ICU postoperatively, I like morphine to deal with the pain, and I like dexmedetomidine to deal with sedation, and I like ketamine a little bit for opioid-sparing reasons, a little bit for prevention of wind-up phenomenon. I don't really like benzodiazepines. I feel they kind of muddy the waters without really lending that much. So, and they're kind of hard to come off. So I don't really like benzos as much. Yeah.
I'm with you on that. I've seen kids kind of behave very peculiarly after prolonged benzodiazepine infusions in ICU. And then, you know, you give enough time for the drug to wash out and they're back to normal. All right, thank you very much.
Yeah, thank you very much for all the participation, for all the speakers' hard work, and especially Kira staying up quite late in her time. And also for our IT support behind the scene, Weber and Teddy. And I just would like to share with you one last thing here. So in order to get your certificate of attendance, please help us to post the post-webinar follow-up survey. It will be available after the webinar is ended, or otherwise it would also be sent to your email. Be sure that you fill in your name and your email correctly. So stay tuned. Our next webinar will be in December, and the topic is Focus in Pediatric Anesthesia. And thank you all very much for today's participation, and we look forward to see you again.
Right, thank you everyone.
Just